Hello everyone, my name is Shiraz Mumtaz and today's topic is renin-angiotensin-aldosterone system and how does it affect the blood pressure, actually the long-term effect. Okay, so objective is what is the renin, what is the renin hormone, okay, and how does it affect the blood pressure and the pathogenesis of the hyperaldosteronism. Okay, we're gonna come in next. Okay, renin is actually a hormone that is actually secreted by a sympathetic stimulation. Okay, uh, actually increase the blood pressure. Okay, what it's doing is eventually is decreasing the blood flow or plasma flow to the kidneys, and eventually decrease the fluid like water and then sodium and chloride delivery at the macula densa. Okay. All right. The renin-angiotensin-aldosterone system, the way it works, okay, the renin is actually secreted by the what is it called, kidney. The what is it going to do is there is a angiotensinogen which is secreted by the liver, and there is converted the angiotensinogen to angiotensin 1. Okay, then the angiotensin converting enzyme, which is secreted by mainly the endothelial cells, mainly the lungs, okay, that is converting the angiotensin 1 to angiotensin 2. Okay, so what is going to do the angiotensin 2 is, what is it called, help in the secretion of the aldosterone from the zona glomerulosa within the kidneys. Okay, what is eventually is going to do causing the vasoconstriction and then also the reabsorption of the kidneys. Okay, and then when the sodium is reabsorbed, the water follows, and also it is going to cause the increase in the blood pressure. Okay, so that's what it is. Okay, so kidney secreting the angiotensinogen, renin, okay, is converting the angiotensinogen to angiotensin 1. The angiotensin converting enzyme is secreted by the endothelial cells, capillary, or any other endothelial cell, which is the lung as well, converting the angiotensin 1 to angiotensin 2. Angiotensin 2 is act on the zona glomerulosa, which is the outermost layer of the adrenal cortex. Okay, then it is going to help in the secretion of the aldosterone, and aldosterone, as we discussed it earlier, that what is going to do, it is helps in the kidney to absorb the sodium, and whenever the sodium is absorbed, they help in the absorption of the water as well, and ultimately causing increasing of the blood pressure or maintaining the blood volume if they need it. Okay, all right. Aldosterone is the hormone is a mineralocorticoid. Okay, as I said earlier, is secreted by a zona glomerulosa. Okay, and it actually helps in the regulating the sodium and then potassium, increasing sodium absorption and increasing the excretion of the potassium. Okay, from the kidney. All right. And then, as I said, that it's what do you call, water follows, as it says. Okay. So this is a picture. That's what it's showing. That what do you call, the adrenal cortex. Okay, it is what do you call, decreasing the blood pressure. Okay, the renin angiotensin aldosterone system causing the adrenal cortex, okay, to secrete the aldosterone. Aldosterone is secreting. Then what it's going to do is what they call the P cell of the collecting duct within the kidneys, causing the what is it called, increase of the reabsorption and increase the secretion, which means that getting rid into the system. The renin-angiotensin, the aldosterone is also activated by increase of the potassium. So whenever there is a increased potassium, it's saying that, hey, I have more potassium, I want to decrease it. Okay, so getting rid of the potassium and reabsorption, getting in the more of the sodium. Okay, all right. So that is the actually the mechanism, the way it is doing, aldosterone, okay, combines with the what is it called, a cytoplasmic receptor. Okay, and then what it's going to do is the hormone receptor complex is going to form. Okay, then it's going to what is it called, increase its transcription. Increase the transcription, what it's going to do is the translation making the more protein and changing the, like, what you call, making the new channels formation, okay, within the lumen, okay, and then causing the increasing of the, what is it called, with these channels, increasing of the sodium reabsorption. And what it's going to do is sodium is going back into the system and potassium in exchange and going into the urine by itself, okay, so causing the hypokalemia and hypernatremia, okay, within the blood. So the aldosterone, why aldosterone matters, okay, whenever, like, the sodium is going to get reabsorbed, water follows, and that causing the, now what is it called, grading of the osmotic pressure and increasing of the blood volume and increasing the, what is it called, blood pressure and blood volume, okay, and the volume depletion decreases the, like, if you decrease the aldosterone, causing the decrease of the blood volume and decrease the blood pressure. That is actually what we, like, newer drug is used, which is the captopril and enalapril, is enalapril, which is the what is it called, suppressing the ACE inhibitor, the angiotensin converting enzyme inhibitor, all the aldosterone receptor inhibitor, which is the valsartan, irbesartan, all the sartan drugs are receptor inhibitor. Okay, all right. Aldosterone, okay, the what do they call, the potassium, the whenever there's a hyperkalemia, okay, there's an electrochemical reaction causing the what do you call, membrane depolarization initially, but causing the what do you call, less excitable, causing the hyperpolarization later on. Hypokalemia causes the, what is called, increasing of the chemical gradient, okay, and membrane is depolarized and become membrane is the hyperpolarized, sorry, and making it less excitable, okay. What happens, like, whenever we have more what is it called, aldosterone, it's called the hyperaldosteronism, okay. The, if it is primary, like, if it is the tumor of the zona glomerulosa, okay, causing the increase of the aldosterone secretion, this is called a Cohen syndrome. The secondary, if it is what is it called, getting the signals from the what is it called, secretion from the, what is it called, increasing of the renin, like, by any means, okay, that causing the called secondary hyperaldosteronism. A symptom, it is going to be increasing of the blood pressure and the hypokalemia, which is the decreasing of the sodium. So this what it shows that how things work, okay. Whenever you see the what is it called, the secretion from the hypothalamus, increasing of the pituitary, causing the increasing of the secretion from the anterior pituitary and posterior pituitary, okay. Basically anterior pituitary is ACTH, okay, causing the increasing of the secretion from the adrenal cortex, causing the release of the cortisol, and then there is more cortisol is released, and then sending the negative signal, less cortisol is released, sending the positive signal, okay. Pathogenesis, how does it happen, okay. So in the what is it called, hyperaldosteronism, the early diagnosis and appropriate treatment of primary hyperaldosteronism is more frequent, okay, the cause of the secondary hyperaldosteronism, okay, and it is crucial to prevent the what is it called, the deleterious or deterioration, actually, cardiovascular outcome, because if there is more blood pressure, more work on the heart, and then heart is going to go to the failure, okay. There is a, what do you call, one of the genetic abnormality, which we're going to come in subsequent next slide, that are sporadic or familial in nature, okay, causing the primary aldosteronism, and that has improved, it has improved the knowledge of the, what is called, pathogenesis of the disorder. So what does it do? Like, there is a mutation, okay, of the, what is it called, the CYP 11B2, okay, that causes the increasing of the expression and autonomous aldosterone production, okay, because of this mutation, okay, and the improved, like, understanding of mechanism underlying the what is it called, disease is a key to improving the diagnostic and developing of the implementing targeted treatments. So if we found out that what happened with the gene, so it is easy to target the aldosterone and then decreasing the aldosterone mechanism production and causing the what are called decreasing the symptoms of the secondary hyperaldosteronism. Okay. um, this review provides the an update on the genetic abnormality which is described earlier. Okay, that the sporadic and the familial familial and sporadic hyperaldosteronism, there's a frequency among the different population and mechanism explaining the excessive aldosterone production and adrenal nodule development. Okay, the what is it called, the possible effect and uses of these findings are improving the diagnostic for hyperaldosteronism are discussed, which I'm going to discuss in subsequent slide. The treatment of the primary hyperaldosteronism, okay, is controlling actually the blood pressure and the cardiovascular symptoms. Also, the called the medical and for the surgical treatment. If there's a treatment, there's a nodule, you can take the nodule out, and that can improve the symptom. Okay, but first, the medically needs to be corrected because we cannot, leave the medical symptoms as it alone by itself because it is going to further deteriorate the symptom. Okay, and the new perspective, regarding the targeted drug, okay, therapy for following for the aldosterone production adenomas with the what they call specific somatic mutations are also addressed. Okay, so basically both the surgical and medical treatment, wherever you can see the we can use the hormone that opposes the production of the aldosterone and then causing the less aldosterone production, and surgical treatment also helps in the surgical treatment of the primary hyperaldosteronism. Thank you.